Alright.
Alrighty, so I have a really special guest today. Would you please introduce yourself? Tell us a little about your background.
Absolutely. Hi, Evan. My name is Dr.Soroush Zaghi. I graduated from Harvard Medical School. I did my ENT residency at UCLA, and then I completed a fellowship in sleep at Stanford. I'm now medical director of the Breathe Institute, where we take a multi-disciplinary approach to pediatric and adult sleep and breathing issues, ranging from everything from myofunctional therapy to ENT treatments to maxillofacial orthodontic treatments. And we're really focused on being able to provide treatments that are outside of mainstream medicine. So we do provide traditional services like CPAP, sleep studies, oral appliance, but we really pride ourselves in being out of the box and really pushing the frontier in research and clinical care. So thanks for having me here today.
Yeah, awesome. So the first question I have is, so you're not part of a large hospital or university. You've kind of done your own thing, and your team has built the Breathe Institute. Why did you do that? What's the purpose?
Yeah, absolutely. So, I was in academics. When I was at Harvard, when I was at UCLA, and then when I finished at Stanford, I stayed on 1 year as faculty. But the problem when you're part of an institution is that your hands are kind of tied in terms of what you can do to push and advance things. The department chairs sometimes don't like a lot of controversy. They want you to stay within guidelines. So if you're doing anything that's outside of guidelines, outside of randomized controlled trials, it makes them a little bit uncomfortable. And I had a job offer at UCLA, and I sat there with the chair, and he said that, if you want to come here, we just want you to kind of stay in your lane, just do ENT treatments, nothing really out of the box. We don't want to offend our OMFS colleagues. We don't want to offend our speech therapy colleagues. And then when I talked about him, he said, you know what, I think you're better off if I give you a clinical appointment here at UCLA, which I hold, but that you do your own private practice so that you don't need my oversight. And so that's the situation now. I have privileges at UCLA Hospital, so I can take patients there, I do treatments there, I lecture there, but I have a private practice, which is outside of insurance guidelines and outside of the oversight of the department.
So is it not only research that you're able to do now with your private practice, but also treatments?
Yes, so we do have research, and we do have IRB approved research projects that we are constantly using to innovate. But the really great thing is that once we figure something out, we're able to implement it within like a few days or a week. So I'm able to change my clinical intake like that. The treatments that we offer, I can bring on any faculty person that I want. We quickly change and adapt to the latest research that's out there, in contrast to the academic setting where it can take 2, 3, 4, 5 years before they even recognize it and then start to implement it. So the treatments and services that we're able to offer tend to be 5 years ahead of traditional academic programs.
I see. But that actually leads me into something interesting is that, so, I've, in my care, I've had a lot of doctors that were aware of what UARS is. I've had a lot that weren't, and I've had some that feel that UARS is now just obstructive sleep apnea. Whatever diagnostic guidelines are for UARS, we just call that obstructive sleep apnea. What exactly is the distinction, and is it an important distinction to keep?
Uh, great perspective. So UARS is different than sleep apnea. UARS is commonly underdiagnosed. So let me kind of start by explaining what sleep apnea is. And so sleep apnea is a condition that as you go from light to deep sleep, all the muscles in the body relax. There's muscles in the tongue and the throat that also relax. And as you go from light to deep sleep into REM sleep, your throat starts to close up, okay? As it starts to close up, you might have some vibration of the soft tissue causes snoring. It might close up to the point where you're not getting enough oxygen and it's bothering you, so you'll wake up. That's a hypopnea. And it may close up completely. If it closes up completely and you're not breathing for 10 seconds and you wake up gasping for air, that's a sleep apnea.
Mm-hmm.
Sleep apnea is a late stage form of the disease. More commonly, you have what are hypopneas, in which the throat is closed up but not completely, but the oxygen levels drop, your body senses a threat, and then you wake up. They combine the apneas and the hypopneas to the apnea-hypopnea index for sleep apnea. What's much more common is something called respiratory effort-related arousals or respiratory disturbance index. And what happens in this case is that something happens, either you have nose blockage or tongue or tonsils or whatever it is, you have a slight narrowing in the throat, a slight obstruction, a slight resistance to airflow, and that slight resistance is enough to wake you up. So patients with UARS don't have any oxygen loss. If your oxygen levels will remain greater than 92% the entire night. If your oxygen levels are going below 92%, that's characteristic of sleep apnea.
Mm-hmm.
So UARS must have high oxygen levels. UARS also does not have an elevated AHI. So the AHI is actually very low, sometimes often less than 5, sometimes like 0 or 1. So if you have an AHI of 0, that's not physiological. Normal people will have an index of like 2, 3, 4, 5, 6. If you have a really low AHI, what that's telling us is that any small narrowing causes you to wake up. And so there's two things here that affects UARS. One is the resistance, but the second thing is the arousal threshold. So what that means is the amount of obstruction you have to wake up. So a lot of people with UARS are light sleepers, and they tend to have some kind of PTSD or trauma or memory that elicits a very strong response to that minor airway obstruction. So you have to treat the obstruction, but then you also have to treat the arousal threshold that we can talk about how to do that.
I understand. That makes me think of another question. I think there's a little bit of this idea, and I don't know how true it is, that there's not only a difference in the arousal threshold that causes a distinction between a UARS patient and OSA, but also there might be certain anatomical differences. I don't know how true this is, but I think a lot of people might be under the assumption that UARS patients are typically thinner or younger or have more like narrower airways as opposed to looser airways. Anatomically speaking, is there a difference between UARS patients and Go ahead.
UARS patients are much better able to compensate for the airway restriction, okay? So think about it like this, okay? If you are sitting there and you have a 200-pound weight on you, there's no way that you can kind of get up. You're going to be crushed by that weight. That's sleep apnea. It's just so severe that it's going to crush you. In UARS, it's not a 200-pound weight. It's like a 40-pound weight, so that it's crushing you, not enough, so you can kind of resist and fight it. Now, the young, fit, healthy patients will be able to resist. They'll be able to wake up, move from side to side. But the people with comorbidities, they can't resist even a little bit of obstruction, and so they'll fall into the sleep apnea category. So the difference between UARS and sleep apnea is actually your body's ability to fight against that resistance. And it's actually adaptive, because you don't want to be losing oxygen levels, because that causes heart attack and stroke. So your body's doing everything that you can to avoid all those issues, the high blood pressure, the diabetes. But the consequence is high sympathetic tone. Your body's in a state of fight or flight. It affects your immune system, your levels of energy, fatigue, concentration, memory, depression, anxiety, and you don't feel good. And it's a lot more motivating for you to get treatment in that context.
I see what you mean. So I definitely get what you mean. So one, I think, issue that is really popular right now when it comes to UARS and obstructive sleep apnea is the issue of these sleep tests. I've had doctors ask me to get a watch pat. I've had different doctors say, no, I need a polysomnography. And my most recent doctor saying, no, nothing's going to work but a PES for us to really understand what's going on. So what should a patient know, and why isn't there some consensus on which diagnostic tool we should use?
Terrific question. So, UARS is not recognized by insurance companies or the medical community. And so the gold standard that we work off of is the AHI and obstructive sleep apnea. A lot of times there's resistance to learning more about UARS because there's no evidence on it and there's no insurance guidelines on it. And so that can be a barrier. So when you're pushing through, you have to kind of put all those things aside and ask yourself, what is UARS? Does it have anything to do with apneas or hypopneas? And the answer to that is no. You measure the apneas and hypopneas to rule out OSA and to make sure that you don't have a hypoxemia issue. but the characteristic issue of UARS is arousals, and arousals can be measured in one of a different ways. They can be measured by peripheral esophageal manometry, like you're describing, the PES studies, where they put a probe into your esophagus. And the deal there is that anytime you wake up, even if it's just a little bit, you have a little bit of a swallow that happens, and they can register that you woke up.
Okay.
That's one way you can look at the arousal, okay? Another way that you can look at arousal is by actually measuring EEG, cortical arousal threshold changes. That there's a little signal that comes up, and that says that, hey, you woke up. But it's not just the arousal that causes the UARS. You can be aroused and not have UARS. What's really problematic is the high degree of sympathetic tone. So for a given arousal, different people may have a different sympathetic response. Just because you wake up, right? Did you wake up in a panic, or did you just kind of wake up kind of calm? So that's why I like measurements of sympathetic tone, fight or flight response, and the watch pat and similar devices, as well as, so there's watch pat, there's night owl, and there's sleep image. What they do is they're measuring sympathetic tone. The watch pat and the night owl measure it based on peripheral arterial tonography, which what means is that when you have a fight or flight response, you have adrenaline that's kicked in. The adrenaline diverts blood away from the periphery towards the center, and then so you'll have a slight loss of signal, and the loss of signal is registered right there on your fingertip. There are other ways of detecting that with sleep image. They can do heart rate variability, which measures the rate of sympathetic versus parasympathetic activity. And so that's what I think is characteristic of UARS, is a disbalance. You need to have access to sympathetic, but also parasympathetic need to be in good balance with each other. If you're too sympathetic, you'll be very, very anxious and high strung and have a very high arousal threshold. But on the contrast, some UARS patients may experience adrenal fatigue, where they have no sympathetic and they have high parasympathetic, and so they're just kind of zonked out, they're really depressed. So it's either the high sympathetic or the high parasympathetic disbalance that's characteristic of UARS.
I see. You mentioned adrenal fatigue. Can you explain that for me? I haven't heard this term.
Okay, so when you have a perceived stress in the environment, okay, that goes to the hypothalamus, that goes to the pituitary gland, and then the pituitary gland releases adrenocorticotropic hormone. The adrenocorticotropic hormone goes to your adrenal gland that sits above your kidney, and it releases cortisol. So that's the signal that happens. You have a perceived threat, your brain interprets that threat, sends out a hormone that says, hey, stress, a bear is coming after you, there's a tiger there. The cortisol goes down on a mainstream level to every organ in your body, puts them in the stress mode, the alarm mode, the red flag mode, and then you can carry out. Now, what happens when you have a lot of stress all the time is that your body is bathed in cortisol. And when your body's bathed in cortisol, you don't respond as well to those fire alarm red flags. You're like, you know what? It's always red flag. Just like, okay, so if we're always raising the fire alarm, we're saying, today we're a level 10, terrorist threat or COVID threat or whatever. After a while, you're like, you know what? So you might start out at level 3, people might be so sensitive. Then you take a level 5, people are still sensitive. After a while, you're like, you know what? Level 5, I'm fine. Everything's fine, So over time, your body has to do more and more super red flags, super intense. And then the adrenal gland poops out. It's like, I'm done. I give up. And then you have no alarm whatsoever. And then your body can't even mount a threat to normal things out there, like bacteria and viruses. And you get sick quickly because you don't have that alarm.
And so is that often what pushes patients from the UARS category to the obstructive sleep apnea category, that they're not even reacting to these alarms and maybe having deeper obstructions?
I don't see that it causes the OSA category. More commonly, I see that it causes extreme depression and fatigue, and starting to get sick a lot, starting to get sinus infections because your body can't react, and just feeling really ill for a variety of illness reasons that people may not diagnose. Sensitivity to mold, things start to come out that your body can't guard against.
I feel like something in my experiences matches just the early beginnings of what you're saying.
Right.
So back to the sleep test. One question I have is, so let's say you're able to you have like a high channel polysomnography, you've got your watch pad on or some similar device, and you've got a PES, and you ranked your AHI and RDI separately with all these tools, what kind of difference in the value and the reading of the diagnosis would you expect? Like, are you going to?
Great question. So let me tell you this. So if you were to repeat the watch pad or the sleep study from one night to the other, the same device, same conditions, you can expect at least 15 and up to 30% variability night to night. Okay. Right. So 15 to 30% variability is a given. All right. From one night to the other. So if you want it to be statistically significant or clinically meaningful, you have to have like a big change, more than 30 or 50% change for it to mean anything. If your AHI goes up by 2 or 3 one night, lower than 2 or 3, it's actually the same, okay? That's number one. Number two, the other thing that's important is how they're measuring the apneas and the hypopneas. Are they measuring the hypopneas with a 3% desaturation rule or 4% desaturation rule? If your insurance company is paying for it, you have Medicare or some other kind of insurance guidelines, they may request the 4% rule. Even if you're using a watch pad and your insurance pays for it, then the only way they'll pay for it is if it's interpreted against the stricter rule. And the reason is that your insurance company actually doesn't want to give you the diagnosis of sleep apnea, because if they do, they have to start paying for stuff. So they make it much more difficult. Again, the distinction is whether or not oxygen levels that drop by 3 counts as a hypopnea, or if it really has to drop by 4. And that can make a huge difference in terms of the apnea-hypopnea index and your chances of scoring above the critical 15 threshold to get a specific diagnosis.
I understand. So if you were to get the exact same night, you got a copy of it, and you were to use the same 3% desaturation threshold with a watch pad and a PES, or a watch pad and a
It'll be different by 15 to 30% between the same studies on the same night, like 20% difference.
Okay, I understand.
Right. Even the different devices, you won't get 100% the same because they're measuring it differently. The PES is measuring it based on the swallows. The watch pad is measuring it based on the peripheral arterial tone. And the sleep study is measuring by the cortical arousals, okay? Not every arousal that you have with the swallow will also be in the cortex and also be on the sympathetic.
I see.
Okay, so that's why you're not going to get each one is measuring something different. So these tools are not measuring UARS. They're measuring cortical arousals, they're measuring esophagus swallowing, and they're measuring sympathetic tone. Now, if you're taking an antidepressant or something like that, that's kind of neutralizing your sympathetic activity, okay? And so these antidepressant medications will blunt your sympathetic signal, and it'll blunt your heart rate variability so you can get an erroneous watch pad signal, okay? If you have a very high arousal threshold, you have acid reflux, something like that, you're going to be swallowing more, your PES signal will go up, okay? If you're in a lab, it's a new environment, you're sleeping there for the first night, you have this thing on your head, you can have the first night effect when you're outside of your own bedroom, and you can have much more cortical arousals. So none of them is perfect. All of them have different limitations, and a good physician will be able to understand the limitations of each tool and learn how to use them together.
Oh, I see. Okay, that's actually very fascinating. Yeah, I read about how the first night effect, like half of your brain is like at a time sleeps heavier than the other half, something like that.
Yeah, so in the first night effect, you don't get as much into REM sleep. And like you said, half your brain is kind of on guard for something that might happen, while the other one kind of rests. And to that effect, you won't get into deep sleep, and you won't have as many apneas and hypopneas. You'll just kind of be like neutral. Again, to register a difference for the UARS, you need to see a change. If you're just awake all night, there will be no change in sympathetic tone. You need to get relaxed and then stressed, relaxed and then stressed for the signal to come out. If you're just like a zombie all night, it'll come out like a flat one.
Does that have anything to do with loop gain? You talk about relaxed and stressed.
Yeah, so in loop gain, what happens, it has more to do with CO2 levels and cortical arousability. So when we're talking about UARS and what we can do, number one, you can resolve the resistance, but number two, you have to work on your sensitivity in a biochemical level to carbon dioxide, as I'll talk about in a second. And the second is mind-body connection, meditation, going into psychotherapy sometimes to really get into the subconscious mind, okay? So for example, if someone's had sexual trauma, they feel unsafe, they were robbed in the middle of the night, you're much more likely to experience symptoms of UARS that is not going to be resolved with any kind of MMA surgery, myofunctional therapy, tongue-tie surgery, really going to require deep psychotherapy to go and unroot that, okay? So I do see patients who have been sexually traumatized by, you know, whoever else when they were young kids and carry that. So you have to be able to ask the appropriate questions, so you don't want to trigger or provoke or make it worse, and then get them into the right category. That being said, I went on an aside there. Your question was, repeat your question about it.
You mentioned how
loop gain. Yeah. Okay. So loop gain happens in sleep apnea, and here's the deal. Okay. So you have a small hypopnea. Okay. So you're breathing shallowly. It's just not enough. Okay. It's just not enough. So what you do is, instead of breathing through your nose, you open your mouth. Now you're breathing through your mouth. Okay. And then your airway obstructs, and you're not breathing, and you're not breathing. Okay. When you start to breathe again, you're going to breathe very quickly, right? You're not going to give a slow breath that you haven't breathed for 10 seconds. You're not going to go and then just be normal. You're going to go, okay? And when you take those deep breaths, you're upping your oxygen, but you're also getting rid of CO2. So you're breathing a lot. You were hypoventilating, and now you're hyperventilating.
Mm-hmm.
You follow me? And when you hyperventilate, now your CO2 levels are really low. Your pH levels increase. The brain says, hey, you're breathing too much, stop breathing. So now you stop breathing, and as you stop breathing, there's no more exhaled pressure. You actually need that the end expiratory pressure to keep your airway open. When you're not breathing, there's no pressure in the throat to keep things open. It just kind of collapses, okay? So now you haven't breathed. It's even worse than before because you haven't breathed for like 15 seconds this time, right? And now when you go to breathe, right, it's stuck. It takes a second to open. It finally opens. And now you're panicked. So you breathe even faster, okay? You breathe even faster. You hyperventilate even more. And then again, your body's like, stop breathing even more. So now you're breathing a lot, not breathing. So this is a loop gain. And the analogy is when you're trying to steer a car and the road's slippery, okay? And you have a little swerve. The best thing to do is just to kind of gently ease it back, right? Or just kind of let it unwind. If you make a little swerve and then you pull it this way and your car goes that way, and then you pull it back and then you pull it back, okay? So that's the loop gain concept, okay? Hope that helps.
Oh, it totally does. So another question I've had is, I've been told so many times that these devices, CPAP, ASV, BiPAP, these positive airway pressure devices, they're the gold standard, and the only thing wrong with them is a matter of compliance. If you can get past the compliance, it's perfect. You calibrate the settings. I've been using CPAP for years now, and I'm still waking up a lot and whatever. So what is the truth here? You know, why are these CPAP devices really as effective? And is there a difference in which you should use for different UARS patients, or, you know?
Yeah, totally. Really good question. So the way CPAP works is that it puts positive airway pressure. It's not oxygen. It's just a constant flow of air to keep the airway open. Again, we said that when the airway collapses, it gets sticky and it gets harder to open up. So on inhale and exhale, it kind of keeps the airway open. Airway pressures can range from 5 to 15 for CPAP. If you get higher than 15 that you need, okay, then that gets really hard to breathe out against when you have 15 centimeters of water pressure. So what they do at that point is they transition you to BiPAP, or bi-level airway pressure. And what happens in BiPAP is that you have a lot of air coming in, and then when you exhale, it calms down. Okay, there's 2 levels. And you might see something like 25 centimeters of water pressure coming in and 10 on the exhale, okay? Again, we understand why you need on the exhale, because if you had 0 on the exhale, the throat would close up on the back end. It would just suck out. Does that make sense?
Yeah, it does.
And then adaptive serial ventilation kind of works with the loop gain idea, and it's working with your way of breathing. It's commonly used for patients with Cheyne-Stokes respiration, heart failure, and more like central type of sleep apnea. In terms of CPAP being the gold standard, if you're looking at, trying to reduce heart attack and stroke, then certainly, CPAP will prevent hypoxemia and have those outcome measures, but we find that at least 50% of people don't tolerate it. And so I think the first line treatment should be things like myofunctional therapy, establishing nasal breathing. CPAP won't work if you have nasal congestion, okay? I much prefer nasal versus full face or mouth. When you're mouth breathing, the tongue is low, okay? When you're nasal breathing, the tongue is high. When the mouth is low, you don't make this suction cup effect to keep your tongue up. And then when you get into REM sleep, the tongue falls back, especially if you're sleeping on your back. Now, if the tongue is back, the CPAP, all it's gonna do is go in the nose and out the mouth, make a circle like that. Or what it can do is it can prevent you from getting into deep sleep. So UARS patients, if they have it because of obesity problems or lateral pharyngeal wall collapse, okay, or soft palate, it will work. If you have the UARS because of tongue base collapse, CPAP will not work, okay? So for tongue base collapse, it doesn't work. For lateral pharyngeal wall collapse, it works really well. For soft palate, it works really well, okay? So it just depends on the pattern of collapse. The other thing to mention is that when you have continuous positive airway pressure, it can cause rebound turbinate hypertrophy, okay? The turbinates need to see a flow of air. If you have constant pressure coming in, your turbinates will swell up to block that pressure. So what they've come up with is something called flex CPAP, or flex, so either C-flex, so CPAP flex, or A-flex, auto CPAP flex. And so what that does is it changes the pressure, so it's not a perfect continuous, but when you inhale and exhale is a variation, and you actually need to have that flow of air in the turbinates to prevent them from getting swollen. So if you have patients out there who are using CPAP and find that as they go throughout the night, the nose is getting congested, consider getting a flex CPAP or just flex APAP in order to help.
Got it. Okay, awesome. That makes sense. I think I should probably look into that. I want to switch gears a little bit. I actually have a Marpy in my mouth right now. I'm on my second try of Marpy before we go to Sarpy. And for those listening, Marpy is a distractor. It's an expander that expands your upper palate. It's screwed into your bone. It stands for Mini Screw Assisted Rapid Palatal Expander, if I remember correctly. And Sarpy is the surgically assisted rapid palatal expander. Basically, if Marpy doesn't work or there's too much resistance, you can make some cuts along the bone to alleviate some of that resistance and help the expansion. And my question is, there's a lot of debate of where to cut. And I barely know really how any of this works. You know, I hear a lot about the mid-palatal cut, Lefort 1 cut, the pteromaxillary disjunction, corticotomies, and whatever. There's a lot of different things. And can you talk about like the effectiveness or which ones are necessary in which cases and what trade-offs there may be or limitations of treatment in terms of like airflow benefits if a patient, you know, needs a Lefort 1 or doesn't need a Lefort 1? Kind of where do you stand on this kind of spectrum of debate?
Totally, a great question. So when we're doing research on these areas, what we first want to do is say, if you did the most possible, all right, would there be a positive outcome, okay? Because you don't want to kind of go in the middle and have a failed study, right? So what we did with Dr. Yoon and Dr. Liu is they went all the way, they did the dome, where they're doing the Lefort and the mid-sagittal, the whole thing. And the research shows in 75 patients or more that is tremendously successful with low risk and low complications and on all these great things. And that's been published with pre and post in-lab sleep studies. That's really the only that's the only one that has research supporting it, is the dome, okay? Mm-hmm. There's also the EASE, which has less data, but that also involves the mid-palatal and a small bilateral Lefort 1 as well, okay? So from there, what they ask is how can you make like less and less cuts, make them more gentle, and what's the critical threshold that you need? And that a lot of the time has to do with the expert hands that you're in and the provider's experience. Just like I do tongue tie surgery, you first start out doing a lot, and then you kind of peel back to see how much you need. Ultimately, the less you cut, the better, the less recovery there is, the less swelling there is. And so definitely there's a trade-off, and I wouldn't I wouldn't say one way is better than the other, but I would just say that you have to really trust your provider's hands and experience and things like that.
I see what you mean. All right, got it. Um, so one of the things also that I think, I feel like when it comes to resolving sleep disordered breathing, sometimes people's paths will look so different from mine. And I'll try to think about why, and it makes me question, the path that I'm on. So, I'm doing, Marpy / MSE, and then going into double jaw surgery, and then getting a genioplasty. That's my current route. And I see a lot of people, in some of the online communities, they're doing something more like they're like AGA or homeoblock, DNA alpha, or they're doing more mewing or orthotropics. I know those are kind of trying to expand the airways skeletally. And then there's also patients who get other things like UPPP surgery, soft tissue surgery, tonsillectomy. There's myofunctional therapy, frenuloplasty. There's so many different routes to choose from. Which of these are effective for different groups? Where do you think there's value? Where do you think we need to do more research? I know this is a huge question,
Yeah,
but
yeah, totally, totally. I think it goes hand in hand with your comments about the sleep studies and which is the best sleep study to treat the problem. And really, we have to understand that these treatments are not treatments for UARS or sleep apnea, okay? Uh, Frenuloplasty is a treatment for tongue tie, okay? Nasal surgery is a treatment for nasal obstruction. Homeoblock and FAGA and MSC are treatments for maxillary deficiency, okay? So you have to really kind of sort it out. And the first step is identifying what is contributing to your sleep apnea. Is it nasal obstruction? Is it poor tongue posture, mobility? Is it inadequate tongue space, okay? So the order that we do it in is first establish nasal breathing, then get the tongue up to the roof of the mouth, expand the upper jaw, expand the lower jaw, of course, making sure that you don't have large tonsils or a floppy soft palate. So it really depends on what's causing the issue in that particular case. And then when you sub it out, if you have maxillary deficiency, okay, do you have a little bit of maxillary deficiency or do you have a lot of maxillary deficiency? And is it dental or is it skeletal? And so based on those kind of things, you can either use a small hammer or a big hammer. The big hammer being surgery, the small hammer being things like light wire treatments like Alpha and Crozat, to removable appliances like the DNA appliance or the homeoblock, to fixed appliances like the FAGA intervention, to SFOT, MSE. There's just so many different things that you can do. And it's really like a menu from like a small hammer to a big hammer. The big hammers are going to be more effective, but also potentially more costly and a little bit more challenging recovery, but it's just going to be like one and done. The milder interventions are going to go more slow. So do you want to cook your eggs on slow heat or high heat in order to get the outcome that you want? And it's a personal judgment that depends on the severity of the case, your age, bone density, and the experience of your provider.
I see. So one of the questions I have in that regard is, actually, I remember you calling these devices, did you call them like orthodontic remodeling devices or
Orthopedic remodeling?
Orthopedic remodeling. So these orthopedic remodeling devices, I see, on some of the Facebook pages I'm in, that there are plenty of full-grown adults using them, claiming great success. And I look at these before and afters and they look great. And then I'm seeing other people saying, oh, they damaged my teeth or whatever. So,
so the one thing you have to consider is that you definitely need to have a good substrate in order for these things to work. If you're not releasing growth hormone because you're not getting into deep sleep, if you don't have enough vitamin D, calcium, if you have a high sympathetic tone, it can affect your gut microbiome, ability to absorb nutrients. All these things are going to affect each person's body's ability to heal, either from surgery or from intervention. The second thing is making sure that the right appliance is being used for the right indication and the expertise of the provider. I've seen successes and I've seen failures with every intervention, and I can swear by that.
Yeah, I bet. Yeah. So, yeah, I think that's something that, like you said just there, I think that's something that's really important for people to understand, is that every treatment that you're going to do has a chance of having an adverse outcome. It's
100%.
always going to happen.
Yeah, 100%. The more potentially effective it is, the more potentially your downside.
Yeah. Alrighty. Another question I have is one of the really fascinating things I learned when I took your course, the Breathe Institute course, was the concept of how the fascia network interacts with your tongue and your upper airway muscles. You've got this deep front line network of tissue holding your muscles together, and it can become tightened or buckled and cause postural issues and worsen sleep disordered breathing. Correct me if I'm wrong on any of that. And then my question is, how does that happen? You know, I know that, I think you mentioned that there are patients with tongue tie who can get that shortened fascia, and then the patients who don't have tongue tie can get it as well.
Yeah.
Is that true?
Yeah, so I'd recommend that you look up work by Tom Myers. He has like a great segment online called Fascial Trains, where he goes and he talks about the different layers of fascia and how they work and how they interact. I also have a lecture on my website with Timothy King that talks a little bit about the fascia system, but just kind of at a high level, all right? So you have muscles and bones, and then you have something that overlies all of that, and that's the fascia. And the fascia works faster than even nerves to contract the muscles, okay? So when you move from one side to the other, okay, it's the fascia system that's kind of the glue that makes everything kind of work in continuity. If you didn't have fascia, everything would just kind of drop. It gives it that tensegrity. Now, if you have fascia that's held in a certain position for a very long time, the fascia can get sticky and it can adhere. And so in many occasions, that's advantageous, okay? If you hurt your shoulder, if you're trying to do forward head posture, the fascia learns to get tight, and that's advantageous to prevent potential injury, okay? Now, if you have a tongue tie, the fascia system is pulled anteriorly and down, and that can cause, through the deep front line, restrictions in other parts of the body, including the shoulder, the diaphragm, the gut, all the way down to the knees and the toes. And when you release it, if it's because of a tongue tie, you can get great benefits. But it's not just about the tongue tie. You can also do fascia therapy and rolfing and massage to loosen up the fascia. There's also laser treatments that heat up the fascia to release it. But it's really interesting and a whole different field of investigation and discovery.
Yeah, you know, that gives me this thought. I always find, and I've definitely had this thought in my own treatment. I try one thing and it doesn't work, and I try another thing and it doesn't work. But as I started to learn a lot more, I realized my path to having like optimal health in regards to my, I don't know what the word would be, like craniofacial abnormalities. My path to that optimal health is going to include so many things, right? I've talked about these different surgeries and expansions, proper tongue posture. I'm probably going to have to do something with my fascia. I have terrible posture. And I think that that's a really big paradigm shift that's kind of happening right now, where it's like, uh, instead of trying a bunch of things in a line, you really do have to take this interdisciplinary approach, this kind of top-down approach, and understand everything that's working together. And and you know, that actually leads me into a question, which is, if you have a patient, let's say like me, I have lots of different issues that kind of all come together, postural and deficiencies in my face. What are some of the like upper limits? Like, how good can I expect to feel, or how much of the damage from growth as a child can I expect to alleviate?
Great question. So we can restore people to full health if they're willing to go there. The problem is that when you first meet a patient, it's hard to convince them of all the treatments that they need, the expense, the duration, especially when you've tried a myriad of other things and it hasn't been successful. So if you've tried, you know, this kind of nose strip, that kind of nose strip, this CPAP, that oral appliance, and then you come to me and I said, I can do all these interventions for you. The first really step is to kind of engender your trust and to improve your motivation, renew your faith in the medical system before you're willing to accept a drastic intervention. So if someone was willing to undergo, you know, MMA surgery, Sarpy, myofunctional therapy, meditation, nutrition, body work, okay? If you're willing to do everything, there's a very, very high chance with that kind of gunshot approach that you're going to resolve the issue through the therapy, through the soft tissue surgery, through the hard tissue surgery, through the meditation, through the nutrition. That's what we hope to do for patients who are willing to have treatment here at the Breathe Institute. We work together as a team in a multidisciplinary fashion, okay? But sometimes patients want to take it easy. They don't have the trust. So what we do in that case, when they want to take it slow, is we start with just establishing nasal breathing. So get your nose working, okay? Make sure that you can tape your lips and breathe for at least 3 minutes, and then tape your lips and make sure that you can breathe for 30 minutes, and then try that overnight. If you can do it successfully, then you're cleared from your nose. If you can't breathe through your nose, that's the first stop. Because if you can't breathe through the nose, the tongue will come down and you will have airway obstruction. So you got to clear your nose. That's first and foremost. The second thing is to improve tongue posture, get the tongue to the roof of the mouth. If you can, that's wonderful. If you cannot get the tongue to the roof of the mouth, then you have to ask yourself, why not? Is it because of a tongue tie? Is it because of tongue tone, lack of practice? Is it because of tongue space? Is it because of a fascial restriction? And then pursue that. The next thing is make sure they don't have any big tonsils. The next thing is to address the maxillary deficiency. And the final thing is the AP dimensions. Once you've done the AP, you know, all the while, we're always taking into account meditation therapy, CO2 levels that can be addressed through buteco breathing, nutrition, and just, you know, kind of making tweaks along the way.
I see. So that leads me into another question, and I think this is my last question, is so if you have the capacity to more or less bring a patient up to full health, you know, given all the time, money, and resources, where is the research headed?
It's individual for each and every patient. So it's not, we start with the small interventions and we work our way up. But there's something that we can offer to each patient along the continuum if they're willing.
Oh, I'm asking, like in the literature, you know, you're currently doing research. A lot of people are doing research. Where is it? Where do you think the
field is going?
Yeah.
I think what I'm personally trying to do in the field is make a distinction between different phenotypes of sleep disordered breathing. So do you have sleep disorder because of nasal, because of tongue tie, and just better identification of what's causing it? Like, Evan, like, why do you have sleep disordered breathing? Is it because of the maxillary or because of something else?
Mm-hmm.
Okay. And it's likely to be a few different things. The maxillary deficiency has caused mouth breathing, which is hyperventilation, which affects the way that your body's biochemistry is, affects your diet choices, the way you sleep. So it's just about unwinding it, and there's no one-size-fits-all solution. It really takes, multidisciplinary team approach to resolve the issues.
I see. Alrighty, well, that was
helpful. I gave you
awesome.
So much information. I talked really fast, but it's recorded, so hopefully people can go back and listen in slow motion to get all the details. And would love to answer any other questions that come up if people found this interesting.
Yeah, thanks again so much for taking the time to speak with me. That was super educational, super fun. I hope we could do this again in the future. Alrighty.
You got it. Be well.
You too,
Good luck, everyone.
Take it easy.
Take care.